Hi, everybody. This is the Rocky Mountain MIRECC Short Takes on Suicide Prevention podcast. I'm Adam Hoffberg, and today's topic is sleep, and it's important as an upstream approach for suicide prevention. We are joined today by Dr. Sarra and Adam. She's both a clinical research psychologist here with the Rocky Mountain MIRECC, as well as an assistant professor at the University of Colorado School of Medicine with the departments of psychiatry and physical medicine and rehabilitation. So welcome, Sarra.
Thanks so much for having me.
Let's just jump right in. Tell us a little bit about yourself and the work you're doing at the Rocky Mountain MIRECC and sort of how you got into this line of work.
All right, sounds good. So as you mentioned, I'm a psychologist here in the Rocky Mountain MIRECC, doing both research as well as clinical work. So I think most relevant to today's topic, I have a secondary research interest or research program investigating the association between things like sleep disturbances and risk for suicide. And as a clinician, I've also delivered several evidence-based therapies or treatments to folks that have sleep disturbances, so things like insomnia as well as nightmares.
So you mentioned you've worked with folks who have various kinds of sleep disturbances like insomnia and nightmares. Can you go into that a little bit more, and what are the different kinds of disturbances?
Sure. So like you said, some of the two biggest sleep disturbances that we see in veterans as well as military service members are insomnia as well as nightmares. But there are other sleep disturbances as well. So things like sleep apnea, circadian rhythm disorder. There's even things like REM behavior disorder, so abnormal behaviors during the sleep period. So a myriad of different sleep disturbances. And one thing we know are that the rates of those sleep disturbances are alarmingly high. So in our recent returnees from the OEF, OIF, OIND cohorts, rates of sleep disturbances have been reported to be as high as 93.5%. And there's even evidence from the Veterans Health Administrative side that over the past 10 years, there's been a 7-fold increase in the prevalence of insomnia diagnoses. Which is really astounding, because I think, if anything, that's an underreporting. So we'll talk about in a little bit that insomnia is often comorbid with many other conditions. So oftentimes it may not be the presenting or primary concern of an appointment, which means that it may not be reported in the medical chart. So that's why I kind of think that it may be even higher than what our rates suggest. And then on the military side, there's been a 19-fold increase in diagnostic rates of insomnia in the previous decade.
So you mentioned that sleep disturbances are often commonly found with other conditions. Could you give us some examples?
Yeah, so we know that insomnia is associated with a lot of numerous negative outcomes to just start off with. So from a military perspective, insomnia or other sleep disturbances are associated with lower odds of deployment, higher odds of leaving military service early, things like impacting combat readiness. And then we also know that sleep disturbances, including insomnia, are both precursors of and comorbid with other disorders. So what that means is insomnia sometimes comes first before things like depression or PTSD or TBI. And what we also know is that insomnia symptoms often remain at clinically high levels and continue to impact functioning even after resolution of comorbid symptoms. So, for example, let's say somebody goes for depression treatment, they get top-notch depression treatment, those symptoms go down. If they also had sleep impairment on board, oftentimes that sleep continues to remain elevated, those sleep problems. So that's why insomnia is such a significant issue, because it exacerbates other symptoms. It can impede in one's ability to meaningfully participate in treatments, so it can actually make it harder to get the treatment that they're striving for. And then it also may just confer risk for future diagnoses.
Mm-hmm. And so just sort of taking that step further, today's topic on suicide prevention, how is that all connected? And are there theories or mechanisms by which this sleep is sort of contributing to suicide risk?
Yeah, the field has really started to examine sleep and its connection with risk for suicide. And over the past 10 years or so, insomnia in particular has consistently emerged as an independent risk factor for things like suicidal ideation, suicide attempts, and death by suicide. And what I mean by independent predictor is that it is associated with increased risk above and beyond things like depression or anxiety or PTSD. So it means it's a really potent risk factor and something that warrants a lot of our attention. So naturally, people have wondered, why is it the case? What is it about sleep problems or something like insomnia that particularly increases vulnerability for suicide? And so one thing that we know is for many reasons, it's not ideal to be awake at night. And one of those reasons is typically when we're sleeping at night, our brain is doing its kind of cleaning up, you can call it. And when we're not doing that, we actually have decreased frontal lobe functioning. So that kind of front area of our brain that really helps us with high-level tasks, it stops working as well because we're not sleeping or we're awake at night. And what that means is that can compromise things like people's ability to problem solve, regulate their emotions. And that's how, or it could be one reason why it impacts risk for suicide.
That's really helpful. Could you take us through, what does it look like to have experiencing insomnia or another kind of sleep disturbance? What would a typical night of sleep look like?
Yeah, so it definitely look different based on what the particular sleep disturbance might be. And of course, for every person, this could look completely different from person to person. But on a very broad, kind of large level, if we're thinking about insomnia, folks can have trouble falling asleep initially. They may have trouble staying asleep, and then they may also have trouble waking up too early. And they may have a couple of those or all three of those on board. So basically, folks may be in bed, laying awake for large portions of time, at minimum for 30 minutes when we're talking about insomnia. And of course, that impacts people's fatigue, which means that it may impact their cognitive abilities, so really having trouble with memory. And so what happens, especially if these types of sleep disturbances become really chronic, there's a lot of distress and hopelessness can come on board. So this belief that, I don't know if things are getting better, I'm trying all these things, but I continue to not be able to sleep. And so people try to start to chase sleep and get sleep as much as they can, which makes a lot of sense. But we'll talk about a little bit later that there's sometimes a paradoxical effect. So actually that backfires and may intensify some of the sleep problems.
So now that we know a little bit more about insomnia, is it treatable?
Definitely. I think that's one of the major messages I hope from the podcast is that we have some really great treatments for insomnia. And one of those is cognitive behavioral therapy for insomnia, or CBTI. And basically, CBTI is based upon what's called a behavioral model of insomnia, as well as Spielman's three-factor diathesis stress model. So that's a lot of fancy terms that I'm going to break down a little bit. So if you imagine acute bouts or really short-lived bouts of insomnia, so something popping up for the first time when it hasn't been there before, according to the model, it's due to an interaction between kind of individual characteristics, so kind of how if we run hot or cold or what we're made up of, interacting with a stressor. And so stressors can be both positive and negative. So it could be like the birth of a baby, which is a really positive thing, but we know that impacts sleep in a lot of ways. Or it could be something that would be more traditionally defined as negative. So perhaps losing a loved one or encountering some other kind of stressor. So initially, when people have insomnia, they start to adopt some strategies, which make sense, to try to get more sleep. So they may spend more time in bed, because that makes sense, right? If you're in bed more, hopefully or hypothetically, you could sleep more. You may try to go to bed earlier in hopes that you'll get more sleep. Or even you start taking naps because you're tired and you just want to get some sleep in.
Right.
And so the troubling thing is that if we keep up those habits, even after the stressor goes down, we're still engaging in what's referred to as unhealthy behaviors for sleep. So it starts to wreak havoc on our ability to receive restorative sleep. So we often use a pizza dough analogy when doing cognitive behavioral therapy for insomnia. So if you imagine the dough that makes up a pizza, if it's condensed and really tight, that means it's good restorative sleep. But what happens when people start to try to get more sleep by doing naps, by going to bed earlier, they start to really stretch that pizza dough. And so we have less of a drive for sleep. Holes start happening in the pizza dough. So what we do in cognitive behavioral therapy for insomnia with a provider, you restrict someone's sleep window. So you kind of start pushing together that dough so that there's less holes inside of it. It leads to more consolidated sleep, restorative sleep, and then people get back on track.
Yeah, that's a really great analogy and does help put a picture in my mind of exactly what CBTI is trying to do. And going back to this idea of restorative sleep and hope, can you connect that back to the suicide risk piece as well?
Yeah, I think, one thing that we know is that cognitive behavioral therapy for insomnia, or CBTI, has been, of course, shown to reduce people's symptoms of insomnia. So it's one of our most effective, most evidence-based treatments. And one reason why treatment for insomnia may be particularly helpful for suicide risk is, one, you're eliminating those sleep problems like we talked about, but it's starting to restore people's hope. Right, they're sleeping again, they're maybe able to problem solve better, they have less dysregulation of their emotions. And also they can see the impact that they can have in their own personal well-being. So obviously you're working with a provider, but you're doing a lot of that work, and it's great successful outcomes that can help people too.
Mm-hmm. So you've told us a little bit about CBTI and how the research has shown that it is effective. Mm-hmm. Why aren't more veterans receiving this treatment?
Yeah, so first and foremost, I want to say that the VA and the military have done an excellent job in rolling out this treatment. So they've really listened to the literature, which has found about 70 to 80% of individuals receiving benefit from CBTI. So they know it's a great evidence-based treatment. And so the military and the VA have started to roll this into their standard of care. So, for example, the VA has incorporated a national rollout of CBTI, training many providers to deliver the treatment. But what we know are that many facilities, especially in the VA, continue to not have sufficient access to trained CBTI providers. And what's also true, if you think back to the rates, when the rates are so high, even if there are trained CBTI providers, there's such a demand. So it's really hard to get those services, even if someone is trained at the facility. So if you imagine a hypothetical of, 1,000 veterans at a large facility wanting CBTI treatment, and there's only one or two providers that do CBTI, as well as a lot of other treatments, it may be hard to access that care. So improving access to care is really critical, because we know that if individuals are more likely to seek treatment for symptoms like insomnia compared to some other mental health diagnoses due to stigma. So again, sleep can be a really nice target for intervention. So we want to make sure that we're delivering this, one, to help people's well-being and their distress, but also, two, it's a great gateway into additional care.
Yeah, I really like that you mentioned that in terms of the stigma and how sleep can sort of be a very approachable thing that you could be able to talk about with your provider. Could you talk a little bit more about that?
Yeah, definitely. So there have been several studies that have shown that individuals engaging in sleep treatment, for example, helps to improve their help-seeking behaviors just generally after that. And then also there's a good amount of qualitative as well as quantitative research that demonstrates that folks are more comfortable talking about sleep as an issue of their mental health or well-being before talking about some other symptoms. So they may not be ready to take those steps into other types of treatment. But again, since sleep is so highly comorbid with these other disorders that we talk about, this is a nice way to kind of ease into it. And people build trust, build rapport. And then because our insomnia treatments are so great, they have really high success and likelihood, and they might be more open to access additional care.
Great. Going back to this idea of supply and demand and access, and what are some workarounds and how can technology help us here?
So it's a really exciting time to think about how internet-based health interventions that are evidence-based, and that's a key thing. There are a lot of things on the internet, right, that people can find many different types of interventions, but there's been this real emergence of health interventions that are evidence-based that really can transcend care in a different way to really start to get to this access issue. So we typically call these health interventions or evidence-based computerized cognitive behavioral therapies. or CBTs for short. There's lots of acronyms in this area. So basically what that means are that people are engaged in those traditional evidence-based therapies that they would face-to-face, but instead via the internet or via their computer. And what happens then if people are doing this through the internet or through their computer, those traditional barriers that we know that are out there for face-to-face care, so things like cost, scheduling and travel demands. So oftentimes providers can only provide care, between 9 and 5, but a lot of people work. So it's really hard to schedule, to take time off work, to have someone watch kids, for example. There are barriers like stigma, and then that fact that we talked about that there's a lack of trained clinicians. These CCBTs can get around some of those barriers. So my colleagues and I here at the Rocky Mountain MIRECC, including Sean Barnes and Jerry Forster and Lisa Brenner, are really interested in examining how CCBTs can be used as part of a step care treatment or step care model. And so what that means is how can we deliver the least complex and most accessible intervention from which treatment benefit is likely upfront to the largest number of people. And so what this means is it allows us to prioritize specialized care to those individuals that need higher levels of care. Fundamentally, the greatest number of individuals who need treatment can receive that treatment upfront without long waits or hardships accessing the care. And what's also neat is that from qualitative studies, we've seen that veterans and service members are starting to have more demand and interest in receiving electronic-based interventions. So it's a nice coupling of both this emerging technology as well as folks' interest in receiving care through that mechanism.
And just that idea that you touched on about reaching the most number of folks and really starting to look at this, as we talked about at the beginning, as sort of a more upstream approach to sort of conquer some of these sleep problems before any suicide risk problems start to surface.
Yeah, you really hit the nail on the head there. When we think about there are a range of different ways that we can intervene to reduce suicide risk. So obviously when folks are suicidal, we can deliver interventions that we also know work from an evidence-based perspective. But that's a limited number of folks, and in some ways it's really on the right of the spectrum. So we want to think about how can we target and help people even before they get to that point, so before they're suicidal. So when we know that insomnia is so closely linked to suicide risk, the idea is if we can help target sleep as an intervention early on, then we're impacting that whole course, that whole progression. So we're reducing really the overall risk of suicide by helping people even before they get to that point.
Great point, and love this work that you're talking about today. So let's talk about some specific examples of these CCBTI interventions. Could you go into that for us?
Yeah, so there are several that exist. I'll concentrate on one that's specific for insomnia today, and that's called SHUTi, or Sleep Healthy Using the Internet. And it's based upon that CBTI model that I talked about earlier. So it's the same thing, the same nuts and bolts. The creators are really some of the large players in the field that have done insomnia research and clinical work, helped to create this particular program. But it's different because it's on the internet. So basically people are engaging in the same type of treatment, the same components, the same cores, but via their computer. And what's really nice about SHUTi is that, it can be probably pretty challenging to keep people engaged if they're doing something over the internet. So hopefully if you're face-to-face with someone, you make a connection, you're coming back to see them as well as work on the treatment. Mm-hmm. So SHUTi is nice in that it's designed to have a lot of interactive features. There's personalized goal setting. People enter in their symptoms and then graphs come back to give them feedback. There's vignettes, automated emails to help them remember. So it's not like they're doing it totally in isolation or that it's the same product for everyone. It's tailored nicely. And what's really great about it, we know that CBTI is evidence-based, and there have been several randomized controlled trials, or RCTs, which are the gold standard evaluation for interventions in our field, supporting the use of SHUTi.
Okay, so SHUTi specifically has been studied.
Yes, definitely. So several different RCTs, there are many underway, and trial after trial, it's been shown to be efficacious in reducing people's insomnia symptoms, so it works.
Mm-hmm. Is this one of those programs that you use in conjunction with a provider, or is it independent, or how does it work?
This one's a little bit different. So you guys had the great podcast with folks talking about the T2 applications that are mobile phone apps that are especially useful and helpful when you're working with let's say a VA or a military provider. Those are adjuncts. They kind of add on and help to improve that treatment. For something like SHUTi, it's completely different because it's standalone. So you don't need to be working with a provider to engage in SHUTi. In fact, SHUTi is sort of your provider.
I see. Okay, just going back to those T2 apps for a second. So the app that we're thinking about is Cognitive Behavioral Therapy for Insomnia Coach. Mm-hmm. Could you touch on that just a bit, even though that's not our focus today?
CBTI Coach, which, like you said, is used in tandem with face-to-face CBTI, is a mobile phone app that I love it. I have it on my phone. You can enter in sleep diaries on there, so it really gets rid of this traditional paper and pencil way that we've done CBTI. So folks can enter their sleep diaries, they can track their sleep, they can record their symptoms, and then there are also some nice tools in there like relaxation that are part of the CBTI intervention. So it's something that they have on hand to really help them improve their outcomes through the treatment. And then the provider that's working with them can use that data back and forth to see how the treatment's going.
Back to SHUTi again. Mm-hmm. I understand you recently had a grant proposal to study this area further. Could you tell us a little bit about what you're looking to pursue?
So definitely with my colleagues that I mentioned earlier, we're interested in seeing if SHUTi works in a veteran population. So even though I mentioned that there are several RCTs, or those randomized controlled trials, showing that SHUTi works, as of yet, none of them have been evaluated in a veteran or military population. So we're interested in testing to ensure that SHUTi works for veterans in this case. That's essential for many reasons, right? So we believe that this will work, but let's say there may need some tailoring or adaptations to it. That's what we'll learn through this particular grant. And if we know that it works, then we can start to use it as this upstream suicide prevention target like we talked about earlier. Mm-hmm. So for example, on a military side, they could use something like SHUTi for folks that have insomnia symptoms, again, way before maybe they have any suicidal ideation, to help really decrease their future risk for suicide. So what we've proposed in the grant is a longitudinal study. So we're going to compare pre and post symptoms of insomnia, as well as some other symptoms, so things like depression or anxiety, suicidal ideation as well. And then we're going to follow up with folks at 6 months and 1 year out to see if those gains maintain over time. And for this particular grant, we're going to be comparing SHUTi versus an educational website control. So that really, sometimes people can just go to a website and get some information about sleep hygiene. So it's mimicking that versus this intervention that's based on that CBTI model.
That sounds like exciting work, and certainly anything that can change the trajectory of suicide risk in this upstream approach and improve people's quality of life sounds like something we need to be funding more.
Well, thank you. I couldn't agree more with that. You know, it holds a lot of promise at minimum for really reducing people's insomnia symptoms and their distress. But I think it's really a unique way to build a portfolio of different types of interventions we're trying to develop for folks.
We'd like to take this now to maybe like some good takeaways. Obviously, folks have patients that they see that may have sleep problems. We may have veterans listening that this may ring true for as well. What kind of takeaways can we give people right now?
I think some of the big takeaways for folks that either work with individuals that have things like sleep disturbances or insomnia, or for veterans that are listening themselves that have insomnia, I can't stress enough how effective CBTI is. So for individuals that have chronic insomnia, it really is one of the best evidence-based therapies that we have to deliver to folks. So there's just a lot of confidence in that. It improves overall well-being and just outcomes across the board. So I think that's one big takeaway. Just in general, CBTI is a great intervention in and of itself. And then these applications or these kind of new things that we're trying to do hopefully will improve access even more so that we can target things like suicide. And another really interesting thing when we think about sleep is that it's really transdiagnostic. So oftentimes sleep is a symptom of many different diagnoses or disorders. What we can pull from the literature is that if we if we treat sleep or help improve those symptoms, it's just going to help across the board too. So that's a nice point for both clinicians as well as potentially veterans. Asking for treatment for sleep is just going to be hugely influential. And then, like we talked about earlier, it can help improve health-seeking behavior. So maybe a great first step for intervention for people.
So thanks again for explaining that. And any final thoughts for today?
Yeah, I think just one thing that I had forgot to mention earlier is that CBTI really has become a first-line treatment, and it's been shown to be as effective as prescription medications. What's really interesting is that CBTI may last longer than medications. So those effects or those improvements seem to be more durable than what we see for folks that receive medications, which is a really notable finding given that many veterans and military service members want to reduce the amount of medications they're on. So this is a great alternative if they're not interested in taking a medication, something that we know works. And we also know that there can be pretty significant side effects that come from medication. So that's just another great alternative.
Thank you. And again, we look forward to having you back to hear more updates on the progress of your research line and just other work that you're doing. That'll be it for today. Thank you all for joining us for the Short Takes on Suicide Prevention podcast. You can learn more about Dr. Nazem and her work by clicking on some of the links that we will have accompany this podcast. Take a moment to subscribe, share with your colleagues, and give us a rating. Until next time, this has been the Short Takes podcast.